I'm Dr. Mahmoud Al-Shikali, medical consultant. Today we're going to speak about the second lecture of chronic kidney disease. In the last lecture, we have gone through the definition of CKD and causes, risk factors, investigation and management. And we have discussed the biopsy and the appropriate investigations for CKD. Today we're going to speak about complications and clinical manifestation of CKD, and we're going to speak about dialysis. Pathophysiology of the manifestation of CKD, and the top of the list is Uremic syndrome. Uremic syndrome usually occurs due to accumulation of toxins, which usually excreted by normal kidneys, but when kidney fails, these protein metabolism products are toxic and they accumulate. And the second consequence of the second cause of uremic syndrome is loss of renal function to maintain fluid and electrolyte and hemostasis and hormonal regulation. And finally, which is also important, is CKD as a condition considered as a progressive systemic inflammation. And this vascular and nutritional consequences, which we're going to speak about in this lecture. So, first, the fluid and electrolyte and acid-base disturbances. As you know, the fluid hemostasis is maintained by normal kidneys. And when we have normal kidney function, the fluid start to reaccumulate, and this is manifested as sodium retention and water retention, which manifested as edema. Edema can be in lower limbs, of a face, and accumulation of fluid in cavities like ascites, pleural effusion, pericardial effusion. This fluid accumulation and sodium retention leads also to hypertension, which is, as we know, itself can be a propagative factor for nephron injury. So it leads to progression of CKD. In such instances, usually in CKD, the combination of water and sodium retention occurs behind the stage 3, usually at stage 4 and 5. And this is fluid retention is characterized by resistance to loop diuretics and in usual doses, because diuretics to function they need to be filtered, and as you know the filtration is impaired, so we need higher dosage of loop diuretics to get natriuresis and diuresis, and we need them in high dosage to function. The only diuretics which can be used in CKD is loop diuretics. Other diuretics like thiazide diuretics, potassium-sparing diuretics are not working or contraindicated. The only metalazone of thiazide diuretics which can be used to augment the function of loop diuretics. We need to mention also to treat this salt and water retention, we need some better advice, and on the top of the list is sodium chloride or salt restriction. In case of loop diuretics resistance and patients still have got edema, we sometimes need to go through dialysis to get rid of excess fluid. The second is potassium. As you know, potassium excretion is mediated by the kidneys, and in CKD we have hyperkalemia as one of the medical emergencies which occurs in CKD, and this is very vital and can lead to morbidity and mortality. As we know, the electrolyte disturbances in CKD is usually too high and too low, hyperkalemia and hypophosphatemia, and we have hypomagnesemia and hypocalcemia. So let's speak about hyperkalemia. Hyperkalemia and CKD precipitated by increased dietary intake, by increased catabolism of proteins, hemolysis and hemorrhage, which is also a complication of CKD, and sometimes stored blood transfusion, which contains large amount of free potassium, can lead to hyperkalemia, and metabolic acidosis usually augments hyperkalemia. And certain medications, especially ACE inhibitors, ARBs, and potassium-sparing diuretics, can lead to hyperkalemia, and these are sometimes, especially ACE inhibitors and ARBs, are one of the main lines of therapy of CKD. But when we give this medication, we have to keep eye on potassium to keep it in the normal range, below 6. Potassium-sparing diuretics are usually contraindicated. About hyperkalemia, we're going to speak about this in a separate lecture. We're going to speak about its manifestation and also about how to manage it. The next metabolic abnormalities is acidosis. As we know, in the CKD, we have the kidney, we have metabolic acidosis. And we know that kidney is the main organ which controls the hemostasis, which is mediated by proximal tubules and distal tubule function. In the proximal tubules, the kidney reabsorb most of excreted bicarbonate, and in the distal tubules, kidney gets rid of or excretes hydrogen ions. This to keep normal pH of the blood. And once kidney failed, this lead to inability of the kidney to acidify the urine. That means accumulation of hydrogen, and that leads to metabolic acidosis. Metabolic acidosis worsened as kidney function also worsened. So we can see it at stage 3, 4, and 5, but mainly at stage 4 and 5. And in mild cases, the pH is rarely goes below 7.35, but in severe conditions, stage 4 and 5, it can be very low. And this is again treated by sodium bicarbonate transfusion, and which we need, or therapy, which we need to maintain bicarbonate more than 20. But the guidelines suggest it should be 22, because they used to say that metabolic acidosis is not harmful, but studies suggest that any degree of metabolic acidosis is associated with net protein catabolism and bone disease. So it should be treated, and it should be kept, bicarbonate should be kept more than 22. The next is disorders of calcium and phosphate metabolism. The disorder of calcium and phosphate metabolism is one of the main manifestations of CKD, one of its major metabolic abnormalities, and it affects skeleton, vascular bed, and extraosseous tissues. The bone manifestation of CKD is classified into high bone turnover disease, like osteoarthritis fibrosis cystica or renal osteodystrophy, secondary hyperparathyroidism, and the second is low bone turnover disease. So we have high bone turnover disease and low bone turnover disease. Low bone turnover disease, in such condition, we don't have hyperparathyroidism. The parathyroid hormone usually low or normal, and we call this a dynamic bone disease and osteomalacia. So to understand the abnormalities in calcium and phosphorus metabolism, we need to understand the role of the kidney in this metabolism. We know that kidney activates vitamin D. It converts vitamin D hydroxy the vitamin D, which is under ultraviolet light, the cortisol under the skin converted to cortisol, which in the liver converted to 25 hydroxy sorry converted to hydroxy converted to hydroxycholecalciferol, which is D2, and this is under action of 1-alpha hydroxylase enzyme. In the kidney, it's converted to 1,25 dihydroxycholecalciferol, which is an active form of vitamin D. And vitamin D usually leads to absorption of calcium and phosphate from the intestine, absorption of calcium and phosphate from the kidneys, and deposition of calcium into the bone. And this is the role of vitamin D. Parathyroid hormone is the hormone which is secreted by 4 parathyroid glands behind the thyroid glands. Its main function is keeping normal serum calcium. It has, in the surface of these 4 glands, we have calcium sensing receptors, which measures calcium in the blood, and once the calcium is high, the parathyroid hormone excretion decreases, and once it is the calcium is low, the parathyroid hormone gland activated and excrete more parathyroid hormone to keep it high or normal. So the parathyroid hormone functions, it targets the intestine indirectly via activation of vitamin D2. So vitamin D2 is activated by 21-alpha hydroxylase enzyme, which is activated by parathyroid hormone. And parathyroid hormone also acts on the kidney by 2 mechanisms. It leads to retention of calcium and excretion of phosphorus. And finally, it acts on the bone by absorption of the calcium from the bone and excretes it into the blood. So it leads to normalization of the calcium level. So these are the main physiological processes. What happens in the CKD? In the CKD, we have hypocalcemia because of lack of alpha-1 hydroxylase enzyme activation of vitamin D, and this leads to hypocalcemia. Hypocalcemia gives by a signal to the parathyroid gland to excrete parathyroid hormone. So we have secondary hyperparathyroidism. Parathyroid hormone, when excreted, it tries to normalize the calcium level in the blood. So it starts to reabsorb calcium from the main storage of calcium in the bone, and this leads to formation of cyst in the bone, and these cysts we call them osteolysis fibrosis cystica, which is histologically consists of abnormal osteoid bone and bone marrow fibrosis. And because these fibrous tissues is disorganized, this leads to bone marrow fibrosis, and this would have effect on the bone marrow function, and this is one of the causes of anemia. And these bone cysts can have different sizes, and when it is large, the vessels in these cysts are fragile and they can lead to bleeding. Once in those cysts we have bleeding, we call this brown tumor. The clinical manifestation of hyperparathyroidism or renal osteodystrophy includes bone pain, fragility fracture, brown tumors, and erythropoietin resistance. This is the main action of parathyroid hormone, but it is not the only action of parathyroid hormone. So parathyroid hormone has also another actions. It is a uremic toxin, and high level is associated with muscle weakness. It can lead hyperparathyroidism also can lead to fibrosis of the cardiac muscles, and because it is a uremic toxin, it can lead to non-specific constitutional symptoms like fatigue. We have also mentioned that it can lead to fibrosis of the bone marrow, and this leads to bone marrow failure and anemia. It also leads to erythropoietin resistance. So we have to keep in mind when treating hyperparathyroidism not to treat only bone disease, but also another manifestation of hyperparathyroidism. And in case of hyperparathyroidism, the calcium uh, which is uh, excreted from the bone starts to circulate into the blood. And we know that vitamin D is vital for the mineralization of the bone, which is lacking. And in such condition, we start to see extra osseous calcification. This calcification can affect basal ganglia in the brain. It can be in the myocardial muscles. It can be in the skeletal muscles. It can be in the skin, and we call this calciphylaxia. So it has different manifestation. It also hyperparathyroidism when it's high and these glands, the parathyroid glands, is continuously stimulated, they can develop not hyperplasia, which is to excrete calcium in response to hypocalcemia, but sometimes these parathyroid glands develop adenoma, and in these adenomas, the excretion of parathyroid hormone, PTH, is autonomous and is not dependent on the calcium level. So we start seeing severe hyperparathyroidism. We call this tertiary hyperparathyroidism. If for such instances, we need only surgical removal of the gland to manage such condition. Second, bone disease, which is low bone turnover disease, or stimulation on the top of the list, and this is easy to understand because it is mainly due to vitamin D deficiency and is augmented by excess aluminium, which have been used in the dialysis and metabolic acidosis. A dynamic bone disease is seen especially in diabetic and elderly patients, characterized by reduced bone volume and mineralization, and may result from excess suppression of parathyroid hormone by vitamin D preparation and calcium containing phosphate binders. So, and excessive calcium exposure. A complication of a dynamic bone disease is fractures and increased vascular and cardiac calcification. لما أخلص. Another aspect of calcium phosphate effect are the effects on cardiovascular system. Hyperphosphatemia leads to increased cardiovascular disease and mortality in cardiovascular disease, while hyperphosphatemia and hypercalcemia, which leads to increased calcium phosphate product, leads to vascular calcification. The magnitude of calcification is proportional to age. And this, once calcification of the endothelium, this leads to atherosclerosis of the blood vessels, and ultimately this leads to cardiovascular abnormalities like ischemic heart disease or stroke. To summarize the calcium and phosphate abnormalities, in the CKD is mediated mainly by low vitamin D and secondary hyperparathyroidism, which leads to reabsorption of the calcium from the bone, and because of lacking vitamin D, this low calcium, leads to extra osseous calcification. Additionally, the second cause of stimulation of parathyroid gland is hyperphosphatemia. Hyperphosphatemia occurs because the failing kidney leads to in the failing kidney, the phosphate uric effect of parathyroid hormone is lost for unknown reason. So the kidney cannot excrete the phosphorus. And once phosphorus accumulates, this is also one of the stimulus of the parathyroid gland to excrete more parathyroid hormones. So we have two stimulus, hypocalcemia and hypercalcemia. And we go into the vicious circle of excretion of parathyroid hormone, which is usually can be due to hyperplasia of the glands, and sometimes we develop autonomous production by adenomas. We call this tertiary hyperparathyroidism. The manifestation of hypercalcemia and hypocalcemia or hypercalcemia and hyperphosphatemia is on the bone. It leads to renal osteodystrophy, which is osteolytic cystic fibrosis, and formation of cysts in the bone with brown tumors. It also leads to fibrosis of the bone marrow canal, and it also leads to bone pain, fragility fractures, and fatigue. The other manifestation of parathyroid hormone, it affects mainly the cardiovascular system. It leads to because increase of calcium phosphate products in the blood, and this leads to intimal damage, and this leads to atherosclerosis of the vessels. So hyperparathyroidism is one of the risk factors which leads to atherosclerosis and increased incidence of myocardial infarction, ischemic heart disease, stroke, peripheral vascular disease, etc. It also parathyroid hormone leads to erythropoietin resistance and bone marrow canal fibrosis, and this can lead to anemia. And it also can lead to fibrosis of the cardiac muscles and extraosseous calcification, like in the basal ganglia, myocardium, renal itself, and skin and muscles. And in the skin, we call this renal calcification. So to manage such condition, we need to break the cycle by improving the calcium level and decreasing the phosphate level. We're going to speak about management later on, but generally, at the start, we need to give vitamin D in appropriate dosage to keep calcium at reasonable normal level, and to decrease, and we give phosphate uric calcium bounders to get rid of hypercalcemia, hyperphosphatemia. This aims to decrease the excretion of parathyroid gland. And there is some medication which is working on the calcium sensing receptors, which gives the parathyroid glands signal that the calcium is normal, and this leads to decreased excretion of parathyroid hormone. But in case we have tertiary hyperparathyroidism, the only solution is surgical removal of the gland where adenoma is present. The second major complication, or the next major complication of CKD, is cardiovascular abnormalities. It is the leading cause of mortality and morbidity in patients with CKD, especially in every stage, but especially at stage 3, 4, and 5. The risk of cardiovascular diseases is increased from 100 to 200 folds in CKD compared to the age-matched and sex-matched population. This dependent again on the stage of CKD. About half of the patients of CKD stage 5 already have advanced cardiovascular complication. Thus, in the management of CKD patient, we should direct the treatment to prevent the cardiovascular complication. What are the risk factors for cardiovascular complication? As you know, the cardiovascular disease is a disease of risk factors. And these risk factors, we know all of them, traditional risk factors, which is modifiable and unmodifiable. This is not our subject. But in CKD, we have CKD-related non-traditional risk factors, which is these factors leads to increased cardiovascular disease in patients with CKD. On the top of the list is anemia and hyperparathyroidism and hyperphosphatemia. Left ventricular hypertrophy due to hypertension or volume overload, microvascular disease, hemodialysis itself is associated with hypotension and hypovolemia, which can lead to ischemic heart disease. And finally, which is important, we have mentioned in the first lecture that the CKD is a state of generalized inflammation. And as you know, cytokines, which is mediators of inflammation, leads to intimal damage, and this leads to atherosclerosis. Heart failure. Heart failure secondary to myocardial ischemia or left ventricular hypertrophy or salt and water retention. So heart failure can be systolic or diastolic or both, and usually congestive. So we have ischemic heart disease and heart failure and hypertension. Hypertension could be the cause in a quarter of cases of CKD, but it can be sequel. We sometimes it's difficult to understand whether it is or to know whether the hypertension was the cause or its sequel. But it is not important to know this piece of information because at the end of the day, we need to treat the hypertension and to keep it as guidelines suggest. So we have to normalize the blood pressure and keep it controlled. We also this By controlling blood pressure, we reduce the progression of CKD itself, and obviously, we're gonna reduce all the cardiovascular complications. The management of hypertension is also pharmacological and non-pharmacological by salt restriction and by mainly we use ACE inhibitors or ARBs to treat hypertension in case of CKD, but we have to keep eye on two things. Creatinine not to rise more than 50% and potassium not to go up above 6. And if to, to, to keep this, we need to start at very low dose and we go up very slowly in 1 or 2 weeks interval. We increase the dose, keeping eye on potassium and creatinine. If it is the creatinine rises more than 50% and the potassium goes behind 6, we may need to stop the medication at once, or we may try to reduce the dose. If this fails, we ultimately need to stop these medications. One of the important cardiovascular complications is pericardial disease of CKD. Pericardial disease is manifested by pericardial pain with respiratory accentuation and accompanied by a friction rub and is diagnostic for uremic pericarditis. Pericarditis can be combined by pericardial effusion that is seen in echocardiography and can sometimes lead to tamponade. Uremic pericarditis is an absolute indication for urgent initiation of dialysis. But in such condition, dialysis should be performed without heparin. In all dialysis except in pericardial disease and GIT bleeding, we do dialysis without heparin. Hematological abnormalities. Hematological abnormalities on the top of the list is anemia. Anemia of CKD is usually anemia of chronic illness and it is normocytic normoclinic anemia. The primary cause is insufficient production of erythropoietin, and we know the kidney excretes erythropoietin, which is one of the growth factors for the main growth factor for the function of erythropoietin is mainly it acts on the stem cells and it redirects them to produce RBCs. The maturation of RBCs is not dependent on erythropoietin. It's dependent mainly on folic acid and its coenzyme B12. So when we have insufficient erythropoietin, the stem cells will not be converted to RBCs. So we have anemia. But this is not the only cause of anemia in CKD. There are more causes to bear in mind, and they are also important in management of CKD. In CKD, patients have diminished RBC survival because of toxins accumulation. The RBC's lifespan is decreased. Secondly, we have bleeding diathesis. Those patients with CKD usually have poor appetite and they can develop iron deficiency, not only because of poor appetite, but also because of increased bleeding and hemodialysis. Hyperparathyroidism, as we have mentioned, leads to resistance of erythropoietin, and it also leads to osteolytic cystic fibrosis with fibrosis of the bone marrow canal, and this also leads to anemia. A state of chronic inflammation, which is mediated by cytokines, inhibits the bone marrow more, and this can be one of the causes of anemia. Other risk factors: folate and vitamin B12 deficiency due to low dietary intake, and anemia of chronic disease. And finally, in the dialysis, they use aluminium. Aluminium toxicity leads to anemia. So the anemia in CKD is multifactorial, and it is important it's important it, by its one of the propagative factors which leads to progression of CKD, and it is one of the main risk factors for cardiovascular disease. And anemia also, especially in children, leads to growth retardation, and sometimes leads to bone mutation, mental capabilities is decreased, etc. So it's vital to manage anemia. To manage anemia in CKD, we need first to make sure that hematinics like iron, B12, and vitamin B12 and folate are normal, because these hematinics, if these are low and we give erythropoietin, the erythropoietin will fail to improve the anemia. So at first we make sure about diet, we make sure about iron level, folate level, and B12. If there is any deficiency, we correct them at first. If this is insufficient, we use erythropoietin injections. So this again, the consequence of anemia is decreased tissue delivery, oxygen delivery and utilization. It increases cardiac output, and as you know, this can lead to heart failure, high output heart failure, ventricular dilatation, and ventricular hypertrophy. The clinical manifestation includes angina, heart failure, decreased cognition and mental activity, and impaired host defense against infection. As you know, RBCs or hemoglobin is one of non-specific immune systems, so those patients can have decreased host defense mechanisms against infection, and in children it leads to growth retardation. The next point is abnormal hemostasis. Patients with CKD may have prolonged bleeding time, decreased activity of platelets factor 3, abnormal platelet aggregation and adhesion, and impaired prothrombin consumption. Clinical manifestations include increased tendency of bleeding and bruising, prolonged bleeding from surgical incisions or trauma, menorrhagia in females, and spontaneous GIT bleeding. So mainly in the CKD we see thrombocytopathy. But as those patients have great susceptibility to bleeding, they also have greater susceptibility to thromboembolism, and this is especially in nephrotic range proteinuria. In nephrotic range proteinuria, there is a loss of antithrombin 3, which is the main anticoagulant, and this leads to disbalance between coagulation system and anticoagulation system. And because the antithrombin 3, which is the main anticoagulant, is lost, the coagulation function prevail, and this leads to thrombosis. Treatment of abnormal hemostasis Abnormal bleeding time and coagulopathy may be reversed by desmopressin in mild cases, IV conjugated estrogens, cryoprecipitate, blood transfusion, and erythropoietin therapy. Optimally, dialysis is the treatment if these are failed. CNS disturbances. CNS disturbances, the CKD affects the CNS at all its level. It affects the brain, it affects the spinal cord, muscle, and neuromuscular junction and peripheral nerves. And they also affect the sensory and the motor nerves. The manifestation of CNS manifestation of CKD includes fatigue, sleep disorders, lethargy, headache, impaired meditation astraxis, muscle irritability, peripheral neuropathy, restless leg syndrome, seizures and myoclonus, coma, muscle cramps. Dialysis also has complication, CNS complication like dialysis disequilibrium syndrome and peripheral neuropathy, and finally myopathy. Peripheral neuropathy occurs at stage 4 and 5 and usually due or it can also not only due to CKD itself, but also can be due to dialysis, as in dialysis there is accumulation of amyloid protein in the nerves and this leads to neuropathy. Initially in the CKD, initially the neuropathy is sensory more than motor, which is reversible, but once it is motor, it is reversible. Lower extremities affected more than upper extremities, and distal part of the extremities affected more than proximal. So it is distal neuropathy more than proximal, like carpal tunnel syndrome. CNS manifestations are usually one of the indications of urgent dialysis, especially any cognitive function impairment or convulsion or astraxis. GIT disturbances. As we have mentioned, GIT manifestation is the commonest manifestation of CKD if it is have manifestation. On the top of the list is anorexia, nausea, vomiting, gastroenteritis, peptic ulcer disease, GIT bleeding, ascites, and peritonitis. And in such conditions, we need, in some condition of GIT bleeding, usually treated by conventional way, but if it is fails, we need dialysis, and this, as we have mentioned, without ever. Endocrine. We know that kidney have multiple endocrine functions: erythropoietin production, renin and RAS system activation, vitamin D activation by alpha-1 hydroxylase. Glucose metabolism is affected also by the kidney because insulin is produced by beta glands, the beta Langerhans cells in the pancreas, and it's excreted mainly by liver 80% and 20% is excreted by the kidneys. It's in the kidney we also have gluconeogenesis. So these are the main endocrine functions, and they all become become affected. Kidney attributes to insulin removal from the circulation, and plasma insulin slightly rises. So if you see a diabetic patient with start to have hypoglycemias, you have to check first the kidney functions to make sure that he's not having CKD. Metformin is one of the main drugs used in the in the diabetes. Is contraindicated in the GFR is low. Nowadays, the guidelines have been changed. Usually, it was contraindicated below the GFR 60. Nowadays, you can be given up to 30, but it is under caution and not more than 1 gram. In women, CKD leads to estrogen level decrease and menstrual abnormalities and infertility. It also affects the pregnancy, and pregnancy affects the CKD, and the CKD affects the pregnancy. So pregnancy may lead to progression of CKD, and this is considered as high risk pregnancy. And CKD itself can lead to abortions and maternal mortality and morbidity. Men can have reduced plasma testosterone level, sexual dysfunction, and oligospermia meso, and they can have gynecomastia. Female can have breast atrophy. Dermatological disturbances, pallor, hyperpigmentation, pruritus, which can be disturbing, even leading patients to commit suicide. And the only solution is dialysis. Ecchymosis, nephrogenic fibrosing dermatopathy, which we called calciphylaxia, and uremic frost. To summarize this lecture, we have spoken about multiple complications of the CKD. On the top of the list, the most important is cardiovascular complication, which is in form of ischemic heart disease and atherosclerosis, pericardial disease, and myocardial diseases like heart failure. And we have mentioned that this can be due to traditional risk factors and CKD related risk factors, which we have mentioned, like anemia, hyperparathyroidism, hyperphosphatemia, etc. And this addressing cardiovascular manifestation of CKD is top priority in the management of CKD. We have spoken about potassium abnormalities, hyperkalemia, acid-base disturbances, metabolic acidosis, sodium and water retention, which is manifested by edema, and we have spoken about diuretic use in such condition. We have spoken about calcium and phosphate abnormalities in details, and about GIT manifestation, CNS manifestation, dermatological, and finally, thank you for your attention. Um, so this is again a completion of the CKD lecture. We have spoken about most of it, but we haven't spoken about dialysis. So dialysis in a CKD can be medical emergency in certain indications. It can be as a routine scheduled dialysis. So let's first start when we should go for dialysis urgently in CKD. As we have mentioned, few indications of dialysis in CKD. We go for dialysis if patients have got fluid accumulation, which is resistant to diuretics, and we also go for dialysis if patients have got uh, pulmonary edema, which is resistant to treatment. Hyperkalemia can be an indication if it fails to medical therapy. And again, severe hyperphosphatemia can be an indication for dialysis. Patients with any CNS manifestation like decreased liver consciousness, astraxis, can be an indication for dialysis. Hypertension and hypertension, which is resistant to medical therapy, can be an indication for urgent dialysis, and pericardial disease, especially uremic pericarditis, is an indication for dialysis. GIT bleeding and pruritus and are also indications of dialysis. So these conditions we go for dialysis urgently. But when we send a patient for routine dialysis, we start dialysis preparation from stage 4, and this needs complete psychological and physical preparation for the patient to accept dialysis. So the modes of dialysis, as you know, is we have peritoneal dialysis and we have hemodialysis. Both have some package rules and some advantages, but nowadays the most widely used worldwide is peritoneal dialysis because it's safer and can be ambulatory or overnight, and patient can continue his life while doing dialysis. The idea is the peritoneum acts as a barrier for dialysis, and we introduce our catheter into the peritoneal cavity where dialysate, which is high in glucose, introduced in the peritoneal cavity and then excreted with waste products. The complication of this way of dialysis. First, the advantages: it is more convenient. Patient can carry on with his life and work. Can be overnight used or ambulatory, so patient can move around during dialysis. It is effective and less bounded. Patient doesn't need to be bound to the dialysate machine for a long time, and it is not having a risk for acquiring some infections like hepatitis B, HIV, or hepatitis C, etc. But because it high in glucose, it can lead to obesity, and because we have some incision in the abdomen, patient could have incisional hernias, and because of introducing some fluid into the peritoneal cavity, patients could have peritonitis. But this can be treated with single dose of intracatheter sevoflurane can be sufficient to treat dialysis. Uh, the peritonitis. The second mode is hemodialysis, which you need venous access and you need dialysis machine. So it is costly and needs patient to stay in the hospital, and patient can acquire some infections, and it also can lead to dialysis disequilibrium syndrome. It can lead to neuropathy, peripheral neuropathy. It also can lead to fistula complication like bleeding, rupture, closure, etc. So it is more risky than peritoneal dialysis, and these are the indication and for dialysis, acute and chronic, and that's it. Thank you.